Today we'll be doing a comprehensive head-to-toe assessment of the patient. To begin, start with your patient's vital signs. We will begin with temperature. Can I have you open your mouth, please? And just put this under your tongue, close your mouth over it. Okay, 98.4. Okay, and 99. Temperatures may vary by which method of thermometry that you're using. We have used an oral thermometer as well as a tympanic thermometer with about roughly 1/2 degrees variance. Next, we'll use a pulse oximeter to record our patient's heart rate and oxygenation. At 97% oxygenation and a heart rate of 69, and these findings are within normal limits. This also gave us an opportunity to secretly count the patient's respirations, which are 14 breaths per minute. We will next take the patient's blood pressure using a manual technique and a pulse obliteration point. Pulse obliteration involves finding the patient's distal pulse. Relax your arm, please. Relax your arm, please. Okay. This is often the radial pulse. And now that we have the patient's radial pulse, we can inflate the blood pressure cuff until we can no longer feel that pulse. So the obliteration point for this patient is about 150 millimeters of mercury. Then release the cuff and prepare to take manual blood pressure. When taking manual blood pressure, inflate the cuff about 20 to 30 millimeters of mercury beyond the pulse obliteration point. Using a manual technique, we now know the patient's blood pressure is 128 over 78 millimeters of mercury. Okay. So using a digital technique, we're finding very similar data. The patient's blood pressure is about 124 over 80. We will next assess our patient's eyes, followed by her visual acuity. To assess the eyes, check for the acronym PERLA, which stands for pupils equal, round, reactive to light, and accommodative. So, I can tell that the patient's pupils are equal, round. Keep your eyes open, please. Reactive to light, and accommodative. We will next assess our patient's conjunctiva and sclera. The sclera should be white, which it is, and on the conjunctiva should not show signs of inflammation or redness. In this case, it does not. We will now assess the patient's visual acuity using a 20-foot Snellen chart. please cover your right eye with your hand. And please read aloud the characters that I point to.
E, F, P, T, O, Z.
Okay, go ahead and switch eyes. We'll begin at the top.
E, F, P, T, O, Z.
Based on where the patient started to commit errors in reading the Snellen chart, we can tell that her left eye has a visual acuity of 20/40, and her right eye has a visual acuity of 20/15. Next, we need to inspect the patient's oral mucosa, gingiva, oropharynx, and tongue for both color and lesioning. To inspect the patient's mucosa and gingiva, we can have her open her mouth and shine a light in. Okay. Okay, the patient's oral mucosa and gingiva are a pink, healthy color. In order to assess the patient's oropharynx, we will need to use a tongue blade to depress the tongue and visualize the upper back of the throat. If I can have you open your mouth and say ah.
Ah,
Again, please.
ah.
It's important to get the tongue really low. Okay. This patient's oropharynx and tongue show no signs of lesioning and also have a pink hail color. I don't see any sores, wounds, or lesions at any point of this patient's mouth. Next, we need to visualize the patient's nasal cavity. Next, we need to visualize the patient's nasal passages for the color and intactness of the nasal mucosa. We should also be checking for any lesioning, edema, or abnormal discharge. To do this, we'll use a nasoscope with a probe cover. Okay. Based on what I can see in the window of the nasoscope, the patient's nasal mucosa is a pink, healthy color. It is also intact with no bleeding, and there's no evidence of lesioning, edema, or any abnormal discharge. Next, we need to palpate the patient's frontal and maxillary sinuses, as well as the patient's thyroid and submandibular lymph nodes. This can be done quickly and easily with a bilateral technique of the hands. This patient shows no signs of tenderness upon palpation of her sinuses. The sinuses do not feel edematous to the touch. The patient's thyroid feels of normal size, and the lymph nodes are largely non-detectable, indicating good immunological health. Next, we will need to visualize the patient's ear canals and tympanic membranes, again checking for any signs of lesioning, swelling, bleeding, or discharge. Gently inserting the otoscope. And if I can have you turn your head, we'll do it again on this side. Okay. This patient's ear canals are pink and hale and healthy with no signs of injury, swelling, or lesioning. We will now test our patient's hearing acuity by rubbing two fingers together close to the ears. Can you hear that?
Mm-hmm.
Can you hear that?
Yes.
Okay. We will also test how our patient perceives sound using the Rene and Weber tests and our tuning fork. Is this louder or is this louder?
The first one's louder.
Okay. And please turn your head.
First one's still louder.
Okay. This patient is perceiving sound better through air conduction than through bone conduction. The Weber test will demonstrate for us which ear has the better acuity for hearing. Which side do you hear that on the loudest?
This side.
Okay. It's typically difficult for a patient to tell which side is louder. However, any history of ear infections or tympanic membrane rupture will often lead the patient to favor one side or the other. Next, we need to assess the patient's respiratory system. This is done by inspecting the thorax for size, shape, symmetry, movement, depth, and effort of breathing. So we observe the patient. We see that the chest composition is a 2-to-1 ratio, which is normal. The thorax is symmetrical. Proper motion of the diaphragm, no accessory muscles being used in breathing. The depth of respiration is about medium, and there's no visible effort or labor associated with breathing, and the breathing here is unlabored. Next, we'll palpate for chest excursion and symmetry. This can be done both posteriorly and anteriorly. We will begin with the anterior aspect of the patient. Okay, again, please. Okay. And if I could have you take a deep breath. Again. In this case, the chest is expanding symmetrically with the inhalation of breath. And so there is noted excursion upon inhalation, and it is symmetrical. Next, we will percuss the posterior aspect of the chest for resonance. Move your hair. Percussion should take place at every intercostal space. And it should be done with the same technique on both sides, meaning the same fingers every time you percuss. And you should get a good resonant note over the lungs. If you're over the scapula or abdominal organs, you will get different notes. This patient is producing resonant notes over her lungs. So we will move on to auscultation. Since we're back here anyway, we'll go ahead and auscultate the posterior aspect first. Please take a deep breath. Again. 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 And again. It's important to listen with both the diaphragm and the bell of the stethoscope. We will repeat with the bell. Please take a deep breath. Again. 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 And again. Before we auscultate the anterior aspect of the chest, we should also listen with the bell and diaphragm to the sidewall. Take a deep breath. Again. Again. And again. On this side, take a deep breath. And again. Breathe, please. And one more time over here. We will now proceed to auscultate the anterior aspect of the chest. Again. 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 And again. With the bell, please breathe. And again. 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 And again. Very good. So there are no adventitious breath sounds or any indicators of pathology. The lungs are clear upon auscultation in all lobes, front, back, and side. We will now assess the patient's cardiovascular system. We will begin by inspecting the chest for any lifts or heaves. There are none. We will also palpate for the point of maximal maximal impulse. This is often located along the midclavicular line near the fifth intercostal space. Okay, and this case is no different. The point of maximal impulse here is the midclavicular line, fifth intercostal space. We will now assess the pulses of the extremities. I could have you remove your shoes and your socks. Okay. Amplitude is graded on a 1 to 4 scale. This patient's pulses are present, and they are 2+ bilaterally in the wrists and 1+ bilaterally in the feet. Next, we need to listen to the patient's heart sounds, noting any abnormal heart sounds, and we also want to check for overall strength, rate, and rhythm. This patient presents with the normal heart sounds, S1, S2, the traditional lub-dub, without any additional heart sounds like S3 or S4. I don't hear any friction rubs, murmurs, or gallops. The patient's heart rate itself has a normal, regular rhythm with a good intensity, and no signs or indicators of any pathology based on auscultation. After listening to the heart sounds, we need to check the patient's capillary refill at the extremities. This can be done by pressing gently on the fingernails and quickly releasing them. Okay, and if I could have you lift your feet, please. Typically, capillary refill of less than 3 seconds indicates proper perfusion of the extremities. I could have you lay on your back, please. We will now check for signs and indicators of deep vein thrombosis using Hohmann's sign. This is done by bending the knee and forcibly dorsiflexing the foot. Is this hurting?
No.
Is this hurting?
No.
Okay. Pain upon forced dorsiflexion of the foot could indicate a deep vein thrombus. Next, we will assess the patient's gastrointestinal system. First, we will check for overall appearance. There seems to be no evidence of eating disorder. The distribution of weight is neither too great nor too little. No signs of malnutrition, and overall a healthy appearance. The abdomen itself is symmetrical without any pulsations. The shape is morphologically normal, and there is no evidence of distension or hernia. Next, we're going to auscultate or listen to all 4 quadrants of the bowel using both the bell and diaphragm of the stethoscope in multiple locations. This patient's bowel sounds are of a normal rate, neither hyper nor hypoactive, and bowel sounds are present in all 4 quadrants. We will now palpate for masses or tenderness in the abdomen using both light and deep palpation. Deeper. While palpating the abdomen, this is also a good time to inspect and palpate the bladder for fullness or distension. If I could have you please lower your pants just about an inch or 2. Okay. There's no visible evidence of bladder distension, and palpation also does not yield any evidence of distension, and percussion of the bladder is yielding the appropriate notes. Okay, you can lift your pants back to where they were. Okay. We will now test for McBurney's sign. This is done by deeply palpating over the right lower quadrant and quickly releasing. Did it hurt more when I pressed in or when I released?
Or when you pressed in.
Okay, so that would be negative for rebound tenderness and negative for McBurney's point. We will also percuss the abdomen for the presence of the liver and stomach, as well as to get a general idea as to their size, shape, and location. If I could have you please roll up your shirt. Okay. Okay. As a solid organ, the liver should yield dull notes. As a hollow organ, the stomach should yield tympanic notes, similar to the bladder. And both the stomach and the bladder have yielded tympanic notes, and the liver has yielded dull notes accordingly. And I now have a good idea as to where these organs are. We will now assess for costovertebral angle using Murphy's sign or Murphy's punch sign. This is done by gently striking the area overlaying the kidney. This angle is formed by the vertebral column and 12th rib. Should be just over the kidney in the retroperitoneal space. Did that cause you any pain?
No.
Did that cause you any pain?
No, it was uncomfortable, but not painful.
Okay, that is a normal response. Any elicitation of sharp pain would indicate pyelonephritis or other infections or inflammation of the kidneys. Next, we will assess our patient's range of motion in the musculoskeletal system. If I could have you make large circles forward with your arms, starting with this one. Okay, and now this one. Okay, and if I could have you raise this arm up, and this one. Okay, very good. And if I could have you move your hips one at a time out to the side. Okay. Okay, please lift your knees straight forward. Okay. Very good. So by inspecting and palpating at the same time, we can easily deduce that there is no crepitus, and we're not feeling any pops or clicks inside the joints. Also, by being involved as closely as we are with the patient here with palpation and being nearby, I can tell that there's no clear evidence of pain upon movement of the joints in the shoulders and the hips. We will now assess for the strength of the joints in the arms, legs, hips, shoulders, and ankles. If I could have you please raise your arms. Okay. Please shrug your shoulders up. Okay. All right, and please have a seat. And lift your knees. And if I could have you bring your feet up onto the bed. And please try to lift your toes back using the ankle joints. Okay. Okay. The patient is able to supply adequate resistance in these joints, and the strength rating here is graded from 0 to 5. Patient is supplying a strength of 4 at all of her major joints. Importantly, we also need to assess the strength of the wrist joints. Try to curl your fingers in. Okay? Turn your hands over and try to push your hands back against mine. Very good. Patient is again evidencing a 4 or 5 strength of the joints in the wrists. We will now assess the patient for scoliosis. This can be done visually and with palpation. Visually, there's no gross curvature of the spine or vertebral column, and we can palpate the vertebra as well. And again, no lateral deviations or scoliotic curvatures. If I could have you lean forward, please. A little bit further. Okay. Once again, with the patient bent, I don't see any scoliotic curvature, nor do I feel any scoliotic curvature. Having assessed the patient's posture and any risk of scoliosis, we should now move on to checking the patient's neurological system. This can be done by asking the patient a few conversational questions. What is your name?
Lorianne,
Okay. Where are you?
I am at the school
Why are you here?
to film the medical stuff.
Okay. What day is it?
It is December 8th, 2017.
Very good. And what time is it?
It is 5:40.
Okay. So based on these questions, we can tell that the patient is alert and oriented. If I could have you please make little rings with your hands, okay, and pull against mine. Pull against mine, okay. And push against my hands. Okay. Very good. All right. So, and just curl like so, and pull against my hands. Very good. And the patient is showing a very good and appropriate grip strength on both sides. Next, we will test the patient's patellar and Achilles reflexes using the broad and pointed side of the hammer. Relax, please. Relax. Relax, please. The patient's muscular spasms upon strike from the hammer indicate good deep tendon reflexes at the patellar and Achilles tendons. We will now perform a Romberg's test to determine nerve health in the vestibulocochlear nerve. If I could have you please stand on one foot. And now close your eyes. The patient is able to maintain balance with the eyes closed, indicating good vestibulocochlear nerve health without the need for undue compensation. Lastly, we will be demonstrating a skin assessment on our pediatric patient here. We will quickly inspect the skin of the face, torso, arms, and legs. There is no evidence of any lesioning or injuries. There are a few minor abrasions indicative of play, but nothing serious. The patient's temperature is warm. Skin turgor indicates good hydration. And there is no noted swelling or varicosities of the skin. The patient's nails are uniformly thin but appropriate for his age and well trimmed with no evidence of damage. And the patient's head does not show any bumps or irregularities and is morphologically normal. Has a good distribution of hair, appropriate to his age and developmental state as well.